Hello everyone, this is Dr. SEHAR from dentabest, your best online mentor for the preparation of INBDE, ADAT, AFK, ADC, or INDH exam. So today I have made this video on one of the topic of prosthodontics. So we are starting our series of lecture for prostho. So the first topic I'm going to take here is the removable partial denture. So whenever we discuss about the partial denture, first of all, we should know what's the definition of partial denture. So partial dentures, they are the processes that are meant to replace the missing teeth of the patient. It's the simplest definition we have. So if the patient has the ability to remove the denture himself or herself, then it is a removable denture. But the fixed denture will be fixed that cannot be removed by the patient but only be removed by the dentist or the clinician. So when we start with the discussion of removable partial denture, first of all, we should know the properties of the denture. So I think we already had a video before on retention, stability and support in the denture. So retention is a property that will prevent the denture from coming out. The support property is going to prevent the denture from going and hitting on the gingiva or on the mucosa. And the stability property will provide resistance against the horizontal movement or the rocking movement. So before we start with the discussion of the partial dentures here, the removable denture, first of all, we should know what is the Kennedy classification, because that's a very important component. So rule 1, so Kennedy classification, you can see this is Kennedy class 1 when you have bilateral posterior edentulous. Then this is Kennedy class 2 when you have unilateral. Only on one side you have the edentulous posteriorly. This is Kennedy class 3 when you have unilateral edentulous space, but on the both the side it is bounded by natural teeth. And this is Kennedy class 4 where you will have the bilateral edentulous space, which is mainly involving the maxillary anterior. You can see it like that, or the mandibular anterior. So this one is crossing the midline. So what are the Applegate rules? So before we can put the Kennedy classification as class 1, class 2, class 3 or the modification spaces. For example, we can also have Kennedy class 2 mod 1. So in which you can have Kennedy class 2 on one side and then you can have mod 1P. You have another posterior teeth missing on the other side. So it become Kennedy class 2 mod 1A, or it can become mod 2P. 2P is when two posteriors are missing on the opposite side. Mod 1A, 2A is based on the anterior teeth. One is missing or two are missing. Now, before we apply this Kennedy classification or modification, we should know about the Applegate rule. So, any kind of extraction, if it has to do, it has to be done before you apply the Kennedy classification, because once you have done the extraction, the classification is going to change. The second and third rule is, if any tooth is missing like second molar, third molar, and you are not replacing them in your denture, then you don't take them in Kennedy classification. Now, when we talk about the other rules here, the most posterior, so the fifth rule is very important here, that the most posterior edentulous area is the one that is determining the classification. Rule 6 is edentulous area other than those determining the classification, as I was telling you. Mod 1A or mod 2A or mod 1A, 1P or 2P, they are called as modification spaces. And for class 4, we do not have any modification space. So first of all, we should know what are different components of RPD. So different components of RPD, if we see this picture, we can say, so the component will be the major connector. So major connector in this picture, this is the lingual bar here. So major connector is that component of RPD that is connecting right side of the arch to the left side of the arch. The second component will be the minor connector. So if you can see here, this vertical component is a minor connector which is connecting the major connector to the other components of the RPD. For example, in this picture, the minor connector is connecting the lingual bar to the rest here, or the cingulum rest seat here. Now the third component is going to be the rest. So if you can see here, there is occlusal rest here. So function of the rest is to mainly provide the vertical support so that the denture is not impinging down or not impinging on the mucosa. So we have different types of rest design. We have the occlusal rest seat, we have the incisal rest seat, cingulum rest seat, canine rest seats. Then you have the component of direct retainers and the indirect retainers. So direct and the indirect retainers. So direct retainers are the clasp. They are the one that are going to give retention to your denture. So you have the suprabulge retainer and the infrabulge retainer. We are going to discuss them in the coming slide. And then we have the indirect retainers. denture base and the artificial teeth. So let us proceed with this. So the denture base is a rest on the foundation to which prosthetic teeth are attached. A direct retainer is a class attached to the abutment tooth. It retains the RPT and stabilizes the other prosthesis. So if you look at the picture here, so I already showed you the picture of the lingual bar. This is the labial bar. That's another mandibular major connector. So if the lingual designs are not possible, then you go for a labial design, because labial design is not going to be that aesthetic. Now, other than the lingual bar design that we discussed on the last slide, this is the lingual plate design. So lingual plate design is used when you do not have more than 3 mm of space available from the free gingival margin to the superior border of the. So let me remind you, so this was the lingual plate design. If you remember, it was one of the mandibular major connectors. So the thickness of the connector itself, the width of the connector is 4 mm, and it should have at least 3 mm of space from the superior border of the connector up to the free gingival margin. That means you need at least 7 mm space in the floor of the mouth to put the lingual bar design. However, if 7 mm of space is not available, then you go for a lingual plate design. So lingual plate design, you can see it's going all the way up till the height of contour or the middle 1/3 contacts of the anterior. So if you have periodontally weakened up tooth, also lingual plate design is pretty good. Now when we talk about the designs of the maxillary major connector, so this design is the most popular design we have, that is called as the AP strap design. So anterior posterior palatal strap design, this design is like a donut design. It has straps both anteriorly and posteriorly, and you can see there is an open window in between. So if the patient has a tori, AP strap design is pretty good. This design has a maximum strength, maximum rigidity, and each of the strap is around 8 mm. And the opening area is 15 times 20 mm. Now, if for this design, there should be at least 3 mm clearance from the vibrating line. But if the tori is big enough not to give 3 mm clearance from the vibrating line, then you have to go for the horseshoe connector, in which you just have the design present interiorly. So this horseshoe design is having least strength and least rigidity. It is usually not recommended design. It's only indicated when the tori is pretty big, inoperable torus, or there is very prominent median palatine suture. So this design is actually contraindicated in class 1 and class 2 arches because there is little cross-arch stabilization. But the maxillary major connector AP strap design can be used for all the maxillary classes.